Hello friends. Today we're going to discuss about National Mental Health Program critique. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about National Mental Health Program, what is the mental health morbidity and mortality in our country, what are the positive aspects, negative aspects of National Mental Health Program, and what is the way forward to fine-tune this National Mental Health Program. That is, how to leverage digital technology to reach the unreached. This video is based upon an important article which I published in Indian Journal of Medical Research. This publication is a viewpoint, and the title of the study is Lesson Learned from National Mental Health Program, a guide to success for the National Health Program for non-communicable diseases. India was the first developing country to formulate National Mental Health Program to ensure mental health care is available to each individual at the community level. National Mental Health Program was launched in 1982. The unit of mental health delivery services was Primary Healthcare Center and Community Healthcare Center. This was a paradigm shift from providing care in a tertiary center to a primary healthcare center. However, this was a very novel idea, but National Mental Health Program has been criticized for failing to achieve the objectives, that is, taking mental health care to the doorsteps. Although there are many national programs which have done well, but unfortunately, National Mental Health Program did not reach the vision and the objective which was supposed to achieve. Hence, in 1998, the National Mental Health Program from PHC level, it was taken to District Mental Health Program. The main reason being is, in National Mental Health Program, the main idea was to take it to the PHC level. However, till 1998, that could not be achieved. Hence, the District Mental Health Program, the main program which was a pilot study done in Bellary by National Institute of Mental Health and Neurosciences, Bangalore, clearly showed that we can provide a good care at the district hospital level. Not only that, they also said we can train the primary healthcare doctors and community healthcare workers to sensitize and to provide care even at the PHC level. Although the shift was focused from PHC to the district hospital. Hence, the DMHP team was planned, a dedicated psychiatrist, psychologist, social worker, and other team members were planned under the DMHP team. And if you look at the National Mental Health Program, the operational arm changed, but however, the main objective of promotion, prevention, early identification, treatment, and rehabilitation continue to be an important objective of National Mental Health Program. NMHP covered all psychiatric illnesses. That's a very important objective which NMHP took, although it is a positive but also negative. I'll be discussing this shortly. Please remember, the mental health care which was promised under NMHP was prevention, promotion, identification, treatment, and rehabilitation of mental illness across all the population in India. That means it spoke about not only persons with mental illness, but also the people who are mentally distressed and the people who are doing well, mental wellness, to continue to reinforce their positive behavior and to keep them healthy. That means this National Mental Health Program not only focused on illness, but also to the people who are mentally distressed and also the people who are well. That is, it covered the spectrum of mental health. If you look at this diagram, which clearly says that National Mental Health Program targeted 100% of the population. If you look at the bottom of the pyramid, it clearly says that promotion and prevention is required up to 85 to 90% of the population. This population, at times of distress, during disaster, because of severe stress, or any other condition, they may go into distress, and some of them may have mental illness, but some of them come back. Regarding this, further, 10 to 15% may develop common mental disorder, and severe mental disorder is hardly 1 to 2%. Here, the National Mental Health Program did not focus just on the tip of the pyramid, it focused even on the prevention, promotion, and also wellness of the base of the pyramid, a large chunk of the population. That means the responsibility of National Mental Health Program is very huge. That means NMHP covered all the population. Further, it covers all psychiatric diagnosis from wellness, distress, and illness. Now let's look into what happens with regard to pathways to care in mental illness. If you look at this diagram, that is mental health care, the pathways to care, this is again a publication which had done in Indian Journal of Psychiatry in 2010. In this, you can clearly see that there are a large chunk of population who received no treatment at all. Further, here these are the people who go to various people. It may be faith healers, it may be temple, they may go to church, masjid. Many a time they even go to family doctors. Most of them have not been trained in psychiatry during their undergraduation or in post graduation. Hence, they miss out common mental disorders, many a time even severe mental disorders. The adequately treated people are those who are in the tip of the pyramid, that is, who have severe mental disorder, who reach either the medical college or the mental hospitals. That means, my dear friends, invariably 85% of the population do not get diagnosis and also they do not have access to treatment. In this regard, there was a national mental health survey done in 2014 and 16 by National Institute of Mental Health and Neurosciences, Bangalore. This is a study which was done by NIMANS, but it was funded by Ministry of Health and Family Welfare. This study was done across India, and in this study, it clearly indicated 10% of the population at any given point of time suffer from one or the other mental illness. In that, common mental disorders were 10% and 0.8% were severe mental disorder. This looks very small, but if you extrapolate to the entire population, entire population of India is approximately 140 crore. 10% means 14 crore population who are suffering from mental illness. Most of them are common mental disorder. Remaining 0.8% means 1 crore have severe mental disorder. This 1 crore population doesn't mean that just 1 crore population. It is 1 crore families who are staying with them also suffer silently because one of their family member is suffering from severe mental illness. Further, if you look at the treatment gap, it clearly said that up to 70 to 85% of them are not on treatment. This is very stunning. Invariably, alcohol use disorders and also psychosis had a huge treatment gap. That means out of 100 patients, only 15% are on treatment. Remaining, they are not on treatment. That means they are continues to suffering from mental illness. Further, they are adding burden to their family members and to the society at large. Similarly, there was a study done by All India Institute of Medical Sciences, New Delhi. This was a study executed, although by AIIMS New Delhi, it was funded by Ministry of Social Justice and Empowerment. The study was titled as Magnitude of Substance Abuse in India, and this study was published in 2019. In this study, they looked into the substance use pattern across the India, and in this, they clearly said that 5.2% of the population have alcohol use problem and 2.7%, that is 2.9 crore population, are addicted to alcohol. In simple word or in the medical word, they are dependent on this alcohol. This is again, it is not just not 2.9 crore, it is 2.9 crore family members are suffering because of alcohol use disorders. Similarly, with regard to cannabis, 25 lakh people are dependent on cannabis. That is, they are addicted to cannabis. That means 25 lakh families are suffering because one of the family member is suffering from cannabis dependence. Similarly, with regard to opioid, 28 lakh people are dependent or addicted to opioid use. That means 28 lakh families are suffering. Similarly, with regard to inhalant abuse, that is solvent abuse, in simple word, petrol. The young kids who who steal petrol and they sniff that. That is 8.5 lakh children in India are dependent on various solvents. Further, if you look at the other drugs, cocaine 3.2 lakh, amphetamine 7 lakhs, hallucinogens 3.4 lakhs. To summarize, my dear friends, 2.9 crore people who are alcohol addicted, zero point 0.8 crore people are illicit drug dependence is there. It is not just the 3.7 crore individuals, it is 3.7 crore families are suffering because of substance use. Now let's look into children and adolescent, what is happening in India. With regard to that, 40% of our population are children. If you consider 140 crore, 48 crore population are less than 18. There was a study done by Savita Malhotra and Patra. They looked into prevalence of child and adolescent psychiatric disorders in India. It was a systematic review and meta-analysis. They looked into 16 community-based studies in children and adolescent. The prevalence rate of psychiatric disorder in child and adolescent population in the community was found to be 6.5%. That means, my dear friends, if it is 6.5%, if you take 48 crore population, 3 crore children are suffering from one or the other mental illness or require professional help. If you look at a geriatric population, 9% of our population are above the age of 60 years. That means 12 crore population. Again, various studies, meta-analysis have said that 10% of the geriatric population have psychiatric morbidity. Depression and anxiety are common. If you extrapolate this data, 1.2 crore geriatric population has one or the other mental illness. If you look at the suicide and death by suicide, in India, the latest report from National Crimes Record Bureau, which was published in December 2023, clearly said that a total of 1,70,921 death by suicide in 2022, my dear friends. That means every day the completed suicide were 468, my dear friends. It is alarming. If you look at the every year figure, as you see here, from 2018 to 2022, death by suicide is slowly increasing from 1,34,000 to 1,70,000. The people who are committing suicide are daily wage earners, and the next one is housewife. So, my dear friends, we need to do something to decrease this death by suicide. Similarly, if you look at this, for every hour, 18 death by suicide, for every 182nd, one death by suicide. Similarly, if you look at the number of people who attempt suicide and they fail, for every one death by suicide, there are 20 people who have attempted and failed. In this regard, it is 20 into 1,70,921. That means every year, 34 lakh people attempt suicide in India. So, if you look at the psychiatric diagnosis in primary health care, if you go to any PHC or else primary care physician, what is the prevalence of psychiatric disorder? Studies across India and also across the world clearly says 25 to 35% of the patients who visit primary healthcare center will have one or the other psychiatric diagnosis, either individual diagnosis or else it may be comorbid with a chronic physical condition. Persons with mental illness visit this primary healthcare hospital 3 times more than the general population. And invariably, the psychiatric disorders complicate not only the physical illness but also the mental illness. If you look at the cardiac illness, the psychiatric comorbidity is 35 to 40%. In endocrinology, 45%. In cancer, 55%, and in renal disease, 45% will have comorbid psychiatric illness. If you look at the psychiatric morbidity, persons with mental illness experience greater morbidity and functional impairment when compared to their counterpart general population who are healthy. Actually, they are wrongly treated with analgesics, multivitamins, benzodiazepines, injections, and IV fluids in PHC. That means, my dear friends, invariably, there are many patients who repeatedly come to PHC. Please do diagnose them, whereas whether they have depression, anxiety disorder, somatization, substance use, hypochondriasis, and various other psychiatric comorbidity. So please do check for them and treat them adequately. The economic burden of psychiatric illness is enormous. It is not just the patient. Along with the patient, one of the family members have to look after them. Hence, there is a loss of productivity not only for the patient but also one another family member. Further, there is a functional impairment, and it also adds misery not only to the patient but also to the family members. And it also causes significant psychiatric morbidity along with physical morbidity, such as it increases the heart disease, diabetes, various hypertension, and back problems. Invariably, psychiatric patients spends 10 to 15 years of their life in disability. That means if they survive for 60 years, 45 years is the healthy period, remaining 15 years they suffer because of psychiatric illness. If you look at the premature morbidity mortality, the patients with mental illness usually will have depression, and because of depression, many a time they have sudden cardiac death. Invariably, the patient who had cardiac illness and who has depression, the mortality increases by 2 to 4 times. Not only that, the studies have clearly said that the people who are suffering from mental illness, they do die 10 to 15 years prematurely than the general population. Not only that, the persons with mental illness are underdiagnosed, untreated in primary care setting. Hence, in this regard, National Mental Health Program, which was started in 1982, did not achieve its full potency even after 4 decades. And why is that? Let's look into that. National health programs, if you look at that, there are communicable disorder programs. It can be RNTPs, RNTCP, that is Revised National Tuberculosis Control Program, National AIDS Control Program, YAS Eradication Program, Leprosy Eradication Program, Guinea worm, vector-borne diseases, National Surveillance Program for Communicable Diseases. Similarly, there are non-communicable disorders National Program, Reproductive and Child Health, National Iodine Deficiency Disorder Control Program, National Cancer Control Program, National Diabetes Control Program, Program for Control of Blindness, Control. When these programs were compared against National Mental Health Program, invariably the National Mental Health Program failed miserably. Why is this so? Let's look into the facts. This is the table again, which was published in IJMR by myself and my friends, that is colleagues. If you look at the number of illnesses in National Mental Health Program is all psychiatric diagnosis. Whereas in national health programs, especially communicable disease, it is only single disorder. Suppose if you are looking at National Tuberculosis Program, it is only tuberculosis. If you look at leprosy program, it is only leprosy. If you take cataract, it is a single disorder. Similarly, defining case was very easy in other disorders, whereas in psychiatric, it is defining a single illness would have been easy, but we are taking a bouquet of all mental illness. That means you are trying to address mental illness as a complete subject across the population. Although it looks very ambitious, but it failed miserably. You cannot treat all mental illness within the community. It is very difficult. Although it was very ambitious, hence it failed miserably. Treatment protocol, if you look at that, since there are more than 300 different mental illness need to be addressed in the community, providing treatment protocol to the PHC doctor is very difficult. Hence, invariably in the national health programs of communicable disorder, single disorder, the treatment protocol are very clear. Training is easy and the treatment duration is very, very specific. Whereas In National Mental Health Program, all mental illness, majority of them are chronic. Hence, the medication has to be given over a period of years and many a time, maybe decades. Training of manpower is very easy in communicable disorder, whereas in National Mental Health Program, you need to teach them entire psychiatry, which for the PHC doctor, which is very difficult. Further, comorbidity is very less in the other disorder, whereas in psychiatry, the comorbidity is the rule of thumb. Course and outcome is very bad in National Mental Health Program, whereas for the tuberculosis, leprosy, the course and outcome is very specific and easy to define. Psychosocial and occasional rehabilitation is very important in mental illness, whereas in other disorders, rehabilitation is not given much importance. Prophylaxis is a must in National Mental Health Program. In other disorders, it may not require, apart from maybe hypertension and diabetes, it is required. Need for continuous medication is very high in National Mental Health Program, similar to any other non-communicable disorder program. In this way, when they had compared National Mental Health Program with the communicable disease, it failed miserably. Hence, if you look at the National Mental Health Program and various policymakers as critiqued whether this National Mental Health Program should be there or removed. If you look at the positive aspects, invariably this National Mental Health Program, which started during 1975 because of the World Health Organization, which clearly said that we need to take mental health to the primary care, that is to the doorstep. Even India launched it. Not only that, it launched in the two important pilot phase. One is Sakalwara and one in Raniket in North India. Though these pilot study played a very crucial role and given data, and hence it was planned and National Mental Health Program was accepted in 1982. Unfortunately, it did not click. Hence, the operational arm of District Mental Health Program came into picture because of Bellary model, which was done by NIMHANS in Karnataka. So this was the first national program on non-communicable disease. All psychiatric illnesses were covered. It not only covered only mental illness, it talked about prevention, promotion, early identification, treatment, and rehabilitation. The complete population, that is, entire population, was the denominator here. And it is that is from infant to the geriatric, that is, womb to tomb population was covered. And National Mental Health Program was a lifetime approach. That means it is the person who is alive may develop mental illness anytime. Hence, they covered the entire population. It covered wellness, it covered distress to disorder. If you look at the negative side of the National Mental Health Program, it was poorly implemented. There was no target or no phased manner approach was planned. The whole basket of mental illness was taken and tried to implement in the community. There was no priority like considering severe mental disorder will be considered first, next can be substance use. Those phased manner attack was not taken, and the complete basket of mental illness was targeted, and the complete population was the target. It never took high risk population, or else it did not take into consideration where substance abuse is very high. Although prevention and promotion was very important, there is no precise interventions are available in 1982, and till date we do not have a robust data which says if you do this kind of prevention we can prevent all mental illness is not there. And again, if you want to get the data, you have to follow up these patients over a period of lifetime. Then only we will come to know, yes, by doing this prevention and promotion strategy, it may be yoga, it may be meditation, it can be life skills training program, whether that can prevent mental illness is a big question need to be answered in a huge population like India. Further, lack of trained mental health human resources was a major drawback for National Mental Health Program. Further, poor political will, poor funding, and also the whole National Mental Health Program revolved around highly professionally trained manpower like psychiatrist, clinical psychologist, psychiatric nurses, and psychiatric social worker. Invariably, all these professionals resisted the task sharing and task shifting. They wanted this National Mental Health Program, which needs to be delivered only by them. This was the biggest enemy for the National Mental Health Program. And one of my teacher has said that leaving mental health care only to the mental health professional is a disaster to any country. Hence, this mental health has to be taken by everyone, every citizen, by every policymaker and political uh, people should consider this, and the mental health care delivery should be done by everyone. Not only that, further poor medication supply, and considering for the mental illness, the treatment duration is very long. It may be for treatment purpose and prophylaxis. It runs from months to years. And there was no systematic campaign against the stigma and discrimination with regard to mental illness. If you look at the critique by mental health policy group, which was established in 2012, and it clearly did a study and they clearly said that there was a political neglect, inadequate leadership, inaccessible funding, poorly implemented delivery services because of poor training, lack of motivation, poor retention of staff, depleted technical support at the district level made this national mental health program a failure. Although the program itself is not a flawed, but the implementation was flawed. Let's look into the contemporary challenges for implementation of national mental health program in India. Awareness of psychiatric illness is very poor. Access to mental health care is very poor. Affordability for mental illness treatment is a big challenge in rural area. Stigma and discrimination, long-standing treatment. Many of this severe mental disorder require treatment for months to years. Poor knowledge of psychiatric illness, especially in doctors. That means many of these doctors who are during UG training, psychiatric illness is completely neglected. And even when we do training for PhD doctor, it is once a year training of 3 to 5 days is very insufficient. The reason being is most of this psychiatric illness requires treatment for longer duration. Many time, patients and family members stop this medication because of stigma and discrimination, and invariably poor knowledge in healthcare professionals usually lead to advising many patients to stop psychiatric medication. Further, lack of trained mental health human resources is a big challenge across India with regard to public and private mental hospitals. The maximum beds may be 45,000. If you take medical colleges and district hospitals, another 20,000 beds you can add. Only private hospitals, 25,000 beds can be added. In total, we may have 90,000 beds for psychiatric patients. If you look at the number of people who are ill is 10 crore. See, for 10 crore population who are mentally ill, we have hardly 90,000 beds. In majority of the public mental hospitals, 30 to 40% have been blocked by the chronic mentally ill patients who are abandoned by their family members. Further, we have 10 to 12,000 psychiatrists in our country to treat 14 crore patients who are ill. That means every psychiatrist need to look after 14,000 patients. At this point of time, as per the US or Canada based numbers, we require 1 lakh psychiatrists. This is as per the developed country. WHO requires 1 psychiatrist per lakh population. That means 1 psychiatrist has to look after 10,000 patients. That means for 1 lakh population, if you take 10%, the people who are having morbidity, that means 1 psychiatrist has to look after 10,000 patients. But invariably, if you look at number of psychiatrists produced every year is 1,000. That means to reach 1 lakh, we require 100 years, provided the population remains constant and none of the psychiatrists die. In this regard, my dear friends, we need to gear up and we need to come up with innovations and groundbreaking mechanisms to address this public health menace of mental illness. In this regard, there was a mental health policy group which was formed and NMHP was revised. And with regard to that, they gave certain recommendations. They spoke about program management. They said that we need to have clear funding, management of funding, coordination between the central and state and district teams has to be clearly managed. Community involvement with regard to national mental health program is very essential, involving NGOs, public private partnership should be very important to implement this program. Technical support has to be thorough, and also overarching technical support and advisory group should be there to tweak this national mental health program on annual, and also it may be twice a year basis. Revitalizing human resources, that is training of doctors, training of community health workers, and various task shifting and task sharing should be done. During this time, we need to ensure quality of care is provided even by the community healthcare workers. We need to incorporate life skill education at the primary, secondary, and also at the university level. Further, Dr. Suresh and his colleagues gave a recommendation as per the IGMR publication. First and the foremost, monitoring and evaluation should be a continuous process. In this regard, they said that we need to leverage digital technology so that the course correction occurs then and there. We need to do a war footing with regard to address the deficiency of human resources. Hence, they have clearly recommended to introduce psychiatry in the undergraduate, and also task shifting and task sharing has to be done. The beds which are there in mental hospital should be utilized for training manpower of post graduation, especially psychiatry. Further, there should be a new cadre of community mental health care workers at the society or the community level, just similar to ASHA care workers. That means these are the people who are in touch with the community, who does a great work to see to that their community comes out of this, especially mental health problems. Supply of medicine should be continuous, and if possible, we need to make sure there is a health card available and the continuous supply of medication occurs. Right to access for mental health care, which has been enshrined in the Section 18 of Mental Health Care Act of 2017, need should be implemented at the earliest. Integrating the partnership with NGO and academic institution is the need of the hour. Operational research has to be done so that if there is a good model is available across the India, that should be considered and implemented. And we need to leverage technology for monitoring and implementation of national mental health program. In this regard, further, what can be done at this point of time? The national mental health program need to be tweaked. We need to implement in a phased manner. That means the next 5 years we need to focus on severe mental disorders such as schizophrenia. The next can be bipolar disorder and the substance use disorder. As you know, cannabis, opioid, and various other substances increasing consumption is occurring in our children and adolescent. We need to address this issue before it is too late. In next 1 to 2 decades, we'll decide how we will address drug abuse menace in India. If we do not start now, we will be too late, and there will be a huge problem with regard to drug abuse. We need to declare war against the stigma and discrimination with regard to mental illness and substance use. We need to train all healthcare professionals with regard to diagnosing, providing first line of treatment, referral, and follow up. And hence, all the PHC doctors, community healthcare workers, we should handhold them in providing care. In this regard, we need to leverage technology, use smartphones, telemedicine for handholding these community healthcare workers and to provide care. Hence, this digital technology is going to change the way we provide mental health care. The digital technology will help us to take the mental health care to the doorsteps. We need to register all severe mental disorders. We need to monitor them monthly basis, do follow up. We need to send medicine to their doorsteps. We should not expect a person with mental illness coming to the hospital. We need to take care to their doorsteps. We need to use technology to predict relapse and prevent relapse. We need to invest in public health, my dear friends. All politicians should know about mental illness and also sensitize them, make aware, and also make sure there is adequate funding with regard to mental illness. Community treatment, especially PHC and community centers and wellness centers, should be adequately geared up to provide care. In this regard, task shifting and task sharing should be done. Army of lay counselors should be deployed across the community, and hence CHC, PHC, and wellness centers to be well prepared to provide mental health care at the doorsteps. Policymakers and the politicians need to be sensitized. Telemedicine and availability of the drugs at the doorsteps should be done. Medicine should be reached the doorsteps. A proactive role should be taken by the government to reach the unreached, my dear friends. To conclude, the wide perception that National Mental Health Program DMHP has failed is entirely not justified. The program is amazing. The program is highly ambitious. The problem is implementation. We did not plan this properly. We did not anticipate the problems with regard to human resources, training of the PHC doctors, handholding them was completely missing. Because of digital technology, my dear friends, we can handhold the community healthcare workers, PHC doctors to provide mental health care to the entire population. And National Mental Health Program is a spectrum of mental health care from wellness to illness, from womb to tomb, and it ranges from entire life scale perspective. Hence, my dear friends, National Mental Health Program is not a failure. It is the implementation, it is the leadership, it is the politician, it is the policymakers who failed us, not the National Mental Health Program. And we need to take this seriously and implement National Mental Health Program, which is a model not only for persons with mental illness, but also non-communicable disorder. There is no health without mental health. Thank you very much for giving your valuable time. Stay safe.